Let's see an NCLEX RN video based on care for critically ill patients with neurological dysfunction. In neurological dysfunctions, we will be dealing with patients having increased ICP, then patients having traumatic brain injuries, stroke, etc. The nurse is caring for a patient who is being transported to the emergency department with clinical manifestations of stroke, which is the priority action upon arrival to the hospital. Establish the time that the patient was last known to be without symptoms. Draw blood for coagulation studies. Perform an electrocardiogram. Perform an ECG. So here we need to establish the correct time of symptom onset. This is essential in gauging the response to the patient's signs and symptoms with clinical manifestations of stroke. So you need to establish the time the patient was last known to be without any symptoms. The nurse has received the following provider orders for a patient who was recently admitted to the emergency department with acute stroke symptoms and time of symptom onset of 70 minutes prior to presentation. Which actions are of highest priority in evaluating this patient and preparing to administer IV RTPA, that is a recombinant tissue plasminogen activator? Establish 2 peripheral IV catheters, check blood glucose, perform bedside swallow screen, check temperature, assist with transport of the patient to CT scan. So, 2 peripheral IVs should be inserted in anticipation of administering IV RTPA. One will be for RTPA infusion and other medication, and other will be for drawing blood, since venipuncture is discouraged for 24 hours after RTPA administration. So insertion of 2 peripheral catheters are required. Then hypoglycemia can mimic stroke signs and symptoms. So we need to obtain a bedside fingerstick glucose, which is very useful in ruling out hypoglycemia as a cause of symptoms. So you need to check blood glucose. A CT scan must be rapidly obtained to rule out the presence of intracerebral hemorrhage as the cause of stroke signs and symptoms. So the patient should be shifted for a CT scan also. The nurse is monitoring a patient receiving RTPA who develops a sudden headache. Which are the priority actions in evaluating the changes in assessment? Decrease the rate of the RTPA infusion, administer Tylenol for pain, stop the RTPA infusion, notify the provider of the change and perform a neurologic assessment. Development of a sudden headache. It is concerning for occurrence of an intracranial hemorrhage. So, we need to discontinue the infusion, we need to notify the provider, and we need to perform a neurological assessment in rapid succession. These are the nursing actions which we need to do. The nurse correlates which rationale to the use of hyperventilation to decrease ICP in a patient after traumatic head injury. To maximize oxygenation, to promote vasoconstriction, to decrease cerebral perfusion, to decrease ventilatory effort. So here we are hyperventilating the patient to decrease the ICP. So what is the rationale? Hyperventilation decreases the partial pressure of carbon dioxide as more carbon dioxide is exhaled with each breath. Decreased partial pressure of carbon dioxide leads to vasoconstriction, which is an important factor in the management of increased ICP. Patient arrives in the ICU with diagnosis of cervical spine fracture at the C6 level after a car crash. The patient has no motor movement below the shoulders, is intubated on mechanical ventilation and is receiving a continuous infusion of an alpha receptor agonist and a fluid bolus of 1 liter normal saline. In planning care for this patient, during the next 12 hours, the nurse should anticipate and prepare for bradycardia, hypervolemia, pulmonary edema, renal failure. The patient is at high risk for bradycardia due to absence of sympathetic innervations below the C6 level, and an unopposed parasympathetic response. It is important for the nurse to anticipate this complication of bradycardia in order to rapidly intervene. Administration of a parasympatholytic, atropine, and transcutaneous or transvenous pacing are possible treatments for bradycardia in neurogenic shock. The nurse is caring for a patient status post-craniotomy for resection of a right frontal tumor. Upon admission, the patient was alert and oriented to person, place and time, moving all the extremities symmetrically, and the cranial nerves were intact. 3 hours after admission, the nurse notes that the patient is slower to awaken than during previous assessments, requiring vigorous shaking and cannot recall location. The patient also exhibits a left pronator drift. What are the nurse's next action? Notify the patient's provider and prepare the patient for a CT. Record vital signs and prepare to draw blood for serum osmolality. Notify the patient's provider and prepare the patient for an MRI scan. Prepare to hang a fluid bolus and notify the patient's provider. So here the patient is post-craniotomy. Notify the patient's provider immediately and anticipate the need for a radiographic imaging in order to determine the cause of the patient's neurological deterioration. The likely cause of neurological deterioration in this patient are cerebral edema or bleeding into the resected tumor bed. A patient is admitted to the neuroscience ICU after a traumatic brain injury. If the goal of ICP monitor insertion is to measure ICP and to drain CSF to control the ICP, which device would the nurse anticipate being inserted? Intraparenchymal sensor, epidural sensor, intraventricular catheter, subarachnoid bolt. The intraventricular catheter allows for ICP monitoring and drainage of CSF. So that is the device. The nurse recognizes which patient is at greatest risk for death secondary to stroke. 36-year-old Caucasian male, a 45-year-old Asian male, a 56-year-old African American female, a 62-year-old Hispanic female. The incidence of stroke is greater in men than women until age 55, and after that the incidence of stroke is greater in women than men. That means after 55 the incidence is more in females. Death from stroke is greater in women, and if they are African American the risk is higher. A patient is admitted to a unit with diagnosis of left middle cerebral artery acute ischemic stroke and is not eligible for thrombolytic therapy. The nurse recognizes that this patient is at high risk for which complication? Delirium, aspiration, bronchospasm, palpitations. Aspiration is a nursing priority due to swallowing difficulty after stroke. The patient may also have a weakened cough, which further exacerbates the risk for aspiration. The nurse receives report on a patient in the ICU with a subarachnoid hemorrhage and clarifies that the date of the patient's initial bleed was 4 days before. The nurse needs this information to gauge the patient's risk of which complication of subarachnoid hemorrhage. Hydrocephalus, aspiration, vasospasm, myocardial ischemia. So, patients with subarachnoid hemorrhage are at risk for vasospasm from day 4 post-bleed through day 14, and the peak risk for vasospasm is during days 5 through 9. The family of a patient who sustained a left temporoparietal subdural hematoma and a bilateral frontal contusion is visiting the patient for the first time and is asking repeatedly when the family member will awaken. What is the best method for the nurse to use for begin education with this family? Providing a detailed diagram of the brain and pointing out the functions of each lobe in order to create a foundation from which the family can understand the patient's injury. Providing a handout printed from the internet on severe traumatic brain injury. assessing the family's level of knowledge and information about the patient's brain injury, and providing general information regarding the uncertainty of the outcome in the first several days after traumatic brain injury, deferring any sharing of information until a formal family conference is held with the medical care team. So, assessment of current level of knowledge of the patient or family's readiness also to learn is essential in beginning the education process. Due to uncertainty surrounding brain injury outcome, particularly in the early phase of care, it is necessary to focus on broad aspects, assuring the family that support and information will be forthcoming as the patient's response to injury is continually assessed. Mr. Stewart, a 58-year-old male, begins slurring his speech, drooling from the left side of his mouth and leaning to the left side during a meeting at work. He has a history of hypertension, high cholesterol and smoking. He takes metoprolol and simvastatin. Mr. Stewart's presenting signs and symptoms and time course of symptoms are indicative of acute ischemic stroke. However, these signs can also indicate increased ICP due to a mass lesion, in particular an intracerebral hemorrhage that involves bleeding into the brain tissue. Exclusion of a hemorrhage as a cause of presenting signs and symptoms can be undertaken with a non-contrast head CT scan that can enable a provider to detect a hemorrhage. Once he arrived in the emergency, Mr. Stewart is examined and his stroke signs are quantified using an NIHSS, that is a National Institute of Health stroke scale, where he scores 22 points, indicating severe stroke symptoms. Mr. Stewart's time of stroke symptom onset is confirmed to be 12:50. Vital signs are recorded to be BP 170/90 mmHg, heart rate 80 beats per minute, rhythm atrial fibrillation, respiratory rate 14. Two IV catheters are placed and blood work is done to evaluate electrolytes and a complete blood count. A finger stick glucose is performed and the result is 100 mg per dl. An emergency CT scan is arranged revealing no intracerebral hemorrhage. After discussing the risk and benefit of IV recombinant tissue plasminogen activator therapy with Mr. Stewart's relatives and evaluating all laboratory work, the stroke team has come with the following conclusions. The RTPA total amount to be given is 74 mg, and in that we need to administer 7.4 mg IV push over 1 minute and the remaining 66.6 mg over 1 hour using an infusion pump. And this RTPA bolus is administered by nurses 1:50 p.m. and continuous infusion starts at 1:52 p.m. Mr. Stewart possesses several modifiable risk factors for stroke such as hypertension, high cholesterol and smoking. His non-modifiable risk factors include his gender and age. This patient undergoes a series of tests including ultrasonography of the carotid arteries to investigate whether a narrowing of one of the blood vessels leading to the brain may have been the cause of stroke. Cardioembolic stroke can be attributed to this type of defect. The diagnostic testing regimen after the patient has experienced a stroke is aimed at determining the cause of stroke, which enables healthcare providers to tailor a secondary prevention program to prevent an occurrence of stroke for the given patient. Education and counseling on smoking cessation are also high priorities for Mr. Stewart. Mr. Stewart is diagnosed with right middle cerebral artery stroke and carotid stenosis of the right carotid artery due to atherosclerosis. Mr. Stewart makes steady progress after evaluations by physical and occupational therapies as well as speech-language pathology. As a strategy to prevent him from experiencing another stroke, he is scheduled for a carotid endarterectomy, a surgical procedure that removes atherosclerotic plaque that has caused extreme narrowing of a blood vessel and stroke. After the carotid endarterectomy, Mr. Stewart is discharged to an acute inpatient rehabilitation facility where he makes steady progress in regaining the use of his left leg and continue to progress in regaining some function of his left arm. This is the case of a patient who had a stroke and how he recovered. The nurse recognizes which findings in Mr. Stewart as modifiable risk factors for stroke. 58 years old, history of hypertension, history of high cholesterol, male, tobacco use. So here the question is about modifiable risk factors. Significant modifiable risk factors for stroke include hypertension, cigarette smoking, hypercholesterolemia, and illicit drug use. So here it is history of hypertension, history of high cholesterol, and tobacco use. Others are non-modifiable. Which diagnostic study is indicated in Mr. Stewart to evaluate cardiac function and assess for a cardioembolic source of a stroke? CT scan, ECG, MRI, ultrasound. An echocardiogram may be ordered to evaluate the current cardiac function and determine whether a cardioembolic source is likely. So ECG to be done. What is the contraindication to the administration of RTPA in a patient with suspected ischemic stroke? Patient who awakens from 6 hours of sleep with symptoms of stroke, neurological impairment based on NIHSS, platelet count 2 lakh mm³, onset of symptoms 2.5 hours before presenting to the emergency department. So here, what are the inclusion criteria for administration of a tissue plasminogen activator you need to know. The inclusion criteria or the indications where we need to give are measurable neurological deficit using a National Institute of Health strokes scale. So it's measurable means it's inclusion criteria. No hemorrhage on head CT, it is inclusion criteria. Time since last time patient was seen to normal is within 3 or 4.45 hours before the IV RTPA infusion was begun. So the time of onset since last time patient was seen to be normal is within 3 or 4.5 hours. That means also it is an indication. Symptoms present for 30 minutes, not rapidly improving or attributable for another disease like seizures or migraine, that is also an indication or we can provide. Imaging of head is consistent with an acute ischemic stroke, not hemorrhagic or brain tumor. At that time also we can go for a tissue plasminogen activator. And if the platelet count is less than 1 lakh mm³, that is an exclusion criteria. And here if you see the patient awakes from 6 hours of sleep with symptoms of stroke. Here we don't know the time of onset of the symptoms. So at this time this is a contraindication. The nurse is monitoring Mr. Stewart after he receives RTPA. Which clinical manifestation indicates an adverse effect of RTPA? Decreasing level of consciousness, hyperglycemia, gastroparesis, productive cough. Decreasing level of consciousness indicate development of intracerebral hemorrhage or cerebral edema. So tissue plasminogen activator, it is a thrombolytic and it can cause bleeding in other systems. So decreasing level of consciousness is an adverse effect. The nurse includes which information in the teaching plan about management of acute ischemic stroke to Mr. Stewart and his family? Stroke risk factors, need for annual CT scan, prevention of aspiration, prevention of deep vein thrombosis, importance of BP control. It is important for the patient and family to understand the risk factors, most importantly the modifiable risk factors, especially hypertension, to decrease the chance of another stroke. Due to potential swallowing impairment, they may require attention to minimize the risk of aspiration. Due to his medication and prior history, he may have a risk of deep vein thrombosis. There is no indication for a need for CT scan in patient who have had a stroke event. So stroke risk factors we need to give teaching. Then prevention of aspiration, prevention of deep vein thrombosis because of his medications and prior history, and importance of BP control. Hope you understood this video. Thank you so much for watching.